Hello everyone, this is Nader Mahmoudi, a member of Value of Health Economics and Policy Research Group at the University of Newcastle, Australia. I'm presenting findings for the paper entitled The Influence of Morbidities on Healthcare Utilization, Informal Care Use and Mortality in Europe's Aging Population. This research has been carried out by these researchers as a part of collaboration between the University of Newcastle and the University of Bologna. Like many other developed regions, the European population is aging, life expectancy is increasing, and multimorbidity is on the rise, which is posing a burden on individuals, policymakers, and healthcare systems. It is estimated that approximately 95% of individuals aged 65 and over are multimorbid, and roughly 50 million individuals in Europe are living with multiple chronic conditions. Multiple morbidities are not only associated with increased utilization of healthcare services, such as length of hospital stay, they are also expected to be related to higher healthcare expenditure and increased risk of death in comparison to individuals without them. However, the level of burden is not restricted to the expenditure, as individuals are likely to rely on informal healthcare, i.e., the provision of care from family and friends. On top of all, the presence of multiple comorbidities is directly linked to the level of self-perceived health status. We use the inclusive share dataset that covers 9 European countries to contribute to the literature in 3 ways. We examined the impact of multimorbidities on various health outcomes in a broader sense. This study also explores the modification effect of time in the impact of multimorbidities on the health outcomes. Lastly, this study evaluates the variations in the impact of multimorbidities among countries with national healthcare system. To investigate the effect of morbidities in older age groups on health-related outcomes, we use the SHARE dataset, which is a survey conducted on Europeans aged 50 and older about their health and well-being, financial status, and housing. The SHARE survey was collected using a random sampling method of door-to-door surveys on a multitude of topics, including areas such as individual demographics, health status, and healthcare utilization. To produce a balanced panel, we include only those nations which participated in waves 1, 2, and 4 to 7, which are Austria, Belgium, Denmark, France, Germany, Italy, Spain, Sweden, and Switzerland. The table here in this slide shows the summary of the sample in the wave 7. As indicated in the beginning of this presentation, this study tests the impact of multimorbidity on various health outcome variables. First of these variables is mortality, which is an indicator variable that takes the value of 1 if the participant dies in the next wave and 0 otherwise. The healthcare utilization is proxied with the self-reported total number of nights that the respondent has stayed in the hospital. 2 types of out-of-pocket expenditures are considered in this study: inpatient and outpatient out-of-pocket expenditures. On the other hand, informal care is an indicator variable that takes the value of 1 if the respondent has received regular help for personal care from someone living in their household in the last 12 months, and 0 otherwise. Finally, self-assessed health status is a categorical variable that indicates respondents' self-selected health status of excellent, very good, good, fair, or poor. The main independent variable in this study is the multimorbidity variable. This variable defined as 0 or 1 chronic condition, which is the baseline, 2 chronic conditions, 3 chronic conditions, 4 or 5 chronic conditions, and 6 or more chronic conditions that are presented in this slide. In order to increase the confidence on the impact of multimorbidities on health outcomes, we also control for other individual factors. These factors include age of individuals, an indicator variable for female individuals, their marital status, education level, employment status, and their household size. We have also included 2 household income proxies, household total net income 1 that represents the household's total net income in previous year in euros based on total household net worth and expenditure, and household total net income 2 that indicates annual income and is built on the reported monthly household income. In this slide, we can also see the base model that is used in this research. For investigations related with time modifications and effect of national healthcare systems in the impact of multimorbidities, we augment this equation with corresponding interaction variables. In this slide, we can see our main findings for the relationships between the number of multimorbidities and dependent variables, including mortality, hospital stay, i.e. the number of nights, inpatient out-of-pocket expenditure, outpatient out-of-pocket expenditure, informal care use, and self-assessed health status. As shown in Model 1, the effects on mortality increases as the number of chronic conditions increases, and each additional comorbidity increases the probability of mortality in the next wave at 1% level of significance. Model 3 and Model 4, which examine the impact of multimorbidities on the inpatient and outpatient out-of-pocket expenditure, show that every additional comorbidity increases the out-of-pocket expenditure. However, this impact is weaker for inpatient out-of-pocket expenses, where the relationship is significant for 4 or more comorbidities at the significance level of 5%. Finally, Model 5 shows that the use of informal care rises when the individuals experience higher number of chronic conditions, whereas self-perceived health status significantly decreases by increase in the number of comorbidities as shown in Model 6. This slide with the next two slides demonstrates the time dynamics in the impact of increase in the number of comorbidities on health outcomes under investigation. The significant interaction between waves and the number of comorbidities in Model 1 show that the relationship between the number of comorbidities and mortality in the next wave increases from wave 4 to wave 6. Model 2, on the other hand, demonstrates that variations between wave 4 and wave 7 in the impact of multimorbidities on hospital stay are only significant when the individuals suffer from 6 or more conditions. While multimorbidity variables don't show any interaction with waves on inpatient out-of-pocket expenditure, the impact of 4 or 5 conditions and 6 plus conditions on outpatient out-of-pocket expenditure in wave 5 and wave 6 is significant. As demonstrated in Model 6, the impact of multimorbidities on self-assessed health decreases over waves 4 to 7 consistently for different levels of comorbidity conditions. However, the decrease is insignificant for waves 4 and 5 when 6 plus comorbidities. Here, we consider that the effect of multimorbidities could be influenced by healthcare system in which the respondent resides, such as a national health service or social health insurance system. In a national health service system, compulsory tax contributions are taken to fund national health care, which enables individuals to a specified set of basic services. Whereas a social insurance system requires individuals to obtain health insurance, which entitles them to services via the health insurance coverage. To assess whether the healthcare environment plays a role in the effect of multiple morbidities on health-related outcomes, we use a variable which takes the value of 1 if the respondent resides in a national health service system, and 0 otherwise. In our sample, a 1 is allocated to Denmark, Italy, Spain, and Sweden with national health service systems. As shown in the Model 1 in this table, the national health system increases the impact of multiple chronic conditions on the rate of mortality, whilst significance between health system and the number of comorbidities differs for the other outcomes. Referring to Model 2, having 2 or more conditions in a national health system has a significantly negative effect on the number of overnight hospital stays. Model 4 indicates that out-of-pocket expenses for outpatient services are expected to decrease if an individual has 2 to 5 chronic conditions and lives in a national health system, whilst out-of-pocket expenditure for inpatient services is only negatively significant at 5% for 3 conditions under the national health system. Although Model 5 shows no effect of number of conditions and national health system on informal care use, there are observable effects at the significance level of 5% for having 3 conditions or 6 plus conditions for self-assessed health status. In conclusion, we could see that increase in the number of chronic conditions directly impacts the mortality in the next wave, hospital stays, out-of-pocket expenditure, informal care use, and self-assessed health status. In conclusion, we observed that the increase in the number of chronic conditions directly impacts on various health-related outcomes. We also investigated the modification impact of time in the relationship between increasing chronic condition and health outcomes. We found out that the impact of multi-morbidities on mortality, healthcare utilization, and out-of-pocket expenditure significantly increases over the wave 4 to wave 7, whereas self-assessed health decreases over wave 4 to wave 7 by increasing the multimorbidities. Finally, the effect of multimorbidities on mortality increases for countries with national healthcare system, whereas the impact of multimorbidities decreases on healthcare utilization, out-of-pocket expenditure, and informal care use.